Good day, everyone. Thank you for coming to this talk on fresh tricuspid cases with G4. My name is Anene Ukaigwe. I have no disclosures. The fourth generation of clip, the G4, in addition to the traditional NT and XT clips, features the NTW and the XTW clips, which are 50% wider in the grasping area. In addition to the extended clip sizes, there's the ability for controlled grasping actuation with the G4 clips that allows for sequential or simultaneous leaflet grasp. There's also the ability for continuous atrial pressure monitoring during the procedure. And currently, the G4 clips are designed for delivery with the clip delivery system and steerable guide catheter for the mitral valve. This all options allow us to individualize our therapies to the pathology and anatomy of the patient. A first case in the experience with the G4 clips for the tricuspid was a 75-year-old man who had undergone cardiac transplantation 20 years earlier and now had severe tricuspid regurgitation due to a flail leaflet. These are his baseline images to show a flail septal leaflet with attendant severe tricuspid regurgitation, and the leaflet gap measured about 20 millimeters in these images. Using modified steering techniques to adapt the mitral clip system to the tricuspid valve, an NTW clip on its clip delivery system was inserted into the steerable guide catheter and miskeyed by rotating the clip delivery system 90 degrees counterclockwise. After the clip was straddled in the right atrium, the steerable guide catheter was rotated 180 degrees counterclockwise. In using the negative deflection on the guide and the A knob, the clip was then steered down to the tricuspid valve. The top left panel shows us test the independent gripper actuation function, and we can see the gripper towards the septal leaflets being raised and lowered. We also see that due to the significant flail gap between both leaflets, that this is going to be a difficult grasp. We tried multiple different attempts at simultaneous grasping, all of which was unsuccessful, and therefore we resorted to using the sequential grasping function of the G4 clip. The anterior leaflet was first grasped, after which the septal leaflet was seen to fall on the clip and then successfully grasped. Leaflet insertion was assessed and the clip was then released. Those residual tricuspid regurgitation. This was addressed again by insertion and grasping and deployment of another NTW clip posterior to the initially placed clip. We then see a 30-day follow-up transthoracic echocardiogram that there is some single leaflet device attachment of the commissural NTW. So this case highlights that sequential leaflet grasping does indeed assist in the treatment of complex anatomy. However, with this, caution must be exercised because with this technique, excessive tension may be placed on the leaflets, increasing the risk of leaflet injury and single leaflet device attachment, which is even more important in the tricuspid valve because the leaflets are thinner than in the mitral valve. Our second case in the experience of tricuspid valve repair with the G4 was a 70-year-old female with severe rheumatic mitral regurgitation and stenosis and severe tricuspid regurgitation who was transferred in cardiogenic shock and multiple organ dysfunction previous to the planned elective surgical mitral and tricuspid valve repair. At this point, she was deemed to have a prohibitive risk for surgical valve interventions, and therefore transcatheter options were pursued. The top images have baseline images, and we see that she has severe tricuspid regurgitation and invasive hemodynamics. She has an elevation in her right atrial pressure with ventricularization of the right atrial pressure tracings. The bottom image is the first positioned and deployed, and with this, although on echocardiogram there is a reduction in the severity of tricuspid regurgitation, the right atrial pressure remains elevated with ventricularization of the pressure tracings. A second clip is then positioned posterior to the first anterior septal clip, and with this, there's a reduction in the right atrial pressure. However, there is persistence of a CV wave consistent with severe tricuspid regurgitation, and this led to us deploying a third clip with further reduction of the severity of tricuspid regurgitation and echocardiogram. And we can see that there starts to be a change in right atrial pressure tracing, but the CV wave is still persistent. A fourth clip was then deployed between the posterior septal leaflet. The severity of the tricuspid regurgitation reduced to mild. There was concomitant improvement in the right atrial pressure tracings, that there was normalization with presence of A, C, V waves and X and Y descents. With this, we see that the tricuspid gradient in diastole was 3 millimeters of mercury at a heart rate of 90 beats per minute. And a follow-up out to 6 months, when this patient had transcatheter mitral valve interventions, the tricuspid gradient remained about 2 to 3 at a heart rate of 70 to 80 beats per minute. This case highlights that synergistic information from echocardiogram and invasive hemodynamics can be successfully used to guide transcatheter tricuspid valve repair, similar to the experience that has already been obtained for transcatheter mitral valve repair and left atrial pressure tracing. A third case was a 79-year-old female with symptomatic severe tricuspid regurgitation and moderate to severe mitral regurgitation within a previously repaired mitral valve, who has been having recurrent heart failure hospitalizations. She was deemed to have a prohibitive surgical risk. So these images show the significant mitral regurgitation and tricuspid regurgitation, but we see from the top two images that she has a capillary malformation in her right atrium. Our initial strategy was to tackle the mitral regurgitation and thereafter the tricuspid regurgitation. And from the top left panel, we see that the trajectory of a transeptal puncture avoids the capillary malformation. Unfortunately, the mitral clip could not be deployed due to significantly elevated gradients, which is not uncommon when clip therapy is performed due to recurrent mitral regurgitation within a repaired valve with a ring. That clip was then withdrawn and steered down towards the tricuspid valve, and a grasp and successful clip deployment was performed. And we do see that with this initial clip deployment, there's no interaction with the capillary malformation. A second clip. So when the second clip was inserted, we can see that there was significant difficulty with steering, that there was a close relationship between the clip delivery system, and the capillary malformation, and all of them moved together at any attempt at clip steering, and therefore the grasp could not be performed. The clip was then withdrawn with this clip delivery system, and when this happened, the capillary malformation was withdrawn with it. And this was the capillary malformation, and it's not difficult to imagine that the clip would have been caught in any one of those holes on this malformation, and this would explain why there was simultaneous movement of the clip, its delivery system, and this capillary malformation. After the capillary malformation was removed, another NTW clip was then inserted, steered down, grasping was completed, and clip deployed with little to no difficulty. Again, this case highlights that interaction with embryologic remnants in the right atrium may occur with transcatheter tricuspid valve repair with clips. This theoretically may be more so with the G4 clips because of its size, but this is something to bear in mind because it's estimated that the prevalence of this embryologic remnants in the right atrium can be as high as 50% size. Here we see that he has a eustachian membrane in the top left panel associated with severe tricuspid regurgitation. On the top left panel, we also see that there's a severe atrial enlargement. Due to conformational changes in the tricuspid annulus in response to this right atrial enlargement, there's a slight superior tilt of the tricuspid valve. When the clip was inserted, there was significant interaction between the clip delivery system and the eustachian valve, and this led to limited or difficulties with steering the clip to compensate for that and to allow grasping of the tricuspid valve with a superior tilt. There was a septal hugger, and a septal hugger correction was performed. With that, the grasping was unsuccessful. And here we see the hugger correction and difficulty with continued grasping of the superiorly tilted tricuspid valve, We noted we were running into challenges because there was now a set in the clip delivery system as demonstrated on the bottom right panel. That clip was withdrawn and another clip was inserted, and when this was done, it was now done with 3D TEE guidance. And what this helped us achieve was to ensure that the trajectory of the clip into the right atrium avoided the eustachian membrane and limited interaction between the clip delivery system and the eustachian membrane. By doing that, we were then able to successfully grasp the tricuspid valve even with its superior tilt. However, for the clip therapy could not be given because of this difficult anatomy. So this case again highlights that eustachian valve and superior tilt is some of the challenges of transcatheter tricuspid valve repair with clips, and that we can still encounter this with the G4 clips, and it makes steering and grasping challenging. Thank you.